Buenas, mi nombre es Juan Granada, presidente del CRF y profesor asociado de Columbia University en Nueva York. La siguiente charla es una charla muy sencilla, pero a la vez muy interesante y muy práctica. Está dada por uno de mis colegas, el doctor Ajay Kirtane, que va a hablar de la utilidad, indicaciones, artefactos y técnica de la angiografía coronaria. Cuando uno está aprendiendo los primeros pasos acerca del cateterismo coronario, uno empieza a volverse muy mecánico desde el punto de vista de cómo se hace la angiografía. Y los que verdaderamente aprendieron el arte de la angiografía de los maestros originales se dieron cuenta o aprendieron técnicas muy importantes de referencia, de corregistro y de seguridad en este procedimiento que ahora se ha convertido en algo rutinario. Para los fellows esta charla es muy importante porque yo les aseguro que van a ver tips y tricks que llamamos acá, que son muy prácticos para el día a día en el cateterismo coronario. También Ajay va a hablar de artefactos que muchas veces son inducidos como pseudolesiones o cosas que vemos en laboratorios de cateterismo que son simplemente solucionadas con técnicas muy sencillas. Y de verdad es una charla muy sencilla, muy práctica y muy interesante, sobre todo para los que están empezando en el campo de la cardiología intervencionista. Espero de verdad que lo disfruten y nos vemos en el próximo capítulo.
And so we'll talk about, what coronary angiography means, what it is, and then ways you have to sort of be better than angiogram alone. We get institutional funding to Columbia and CRF from a variety of sources, but nothing personal for these talks or otherwise. I do want to start off by saying, we need to recognize we're here, we're in an interventional meeting, but there are a lot of people who say you shouldn't go to the cath lab because you're going to end up with a stent or otherwise. And it is important to recognize that diagnosing and treating anatomically severe coronary disease is not only important in terms of managing patients' symptoms, but it's also prognostically important. Patients with severe disease, left main, triple vessel, and otherwise, they do get a survival advantage from diagnosing that disease. How you treat them subsequently is based upon how you formulate the case, and through the course of this meeting we'll be talking about how to formulate cases to make those determinations. And so to start, coronary anatomy is an important arbiter of risk. It's not just what the nuclear stress test shows, it's what has been seen on the angiogram. And for those that forget, all clinical trials that are used to sort of disparage the use of coronary revascularization, Courage, Barry 2D, Orbita, and by the way, even ischemia, triage patients based upon an anatomic definition of coronary disease. Even in ischemia, which is testing a strategy of upfront, cath versus no cath, there's a CTA that's done to make sure that patients don't have left main disease, because bad disease is prognostically important. And so if we don't do an angiogram, and that includes a CTA, and I'm totally fine with a CTA in selected circumstances to make this determination, how do we know the patient doesn't have prognostically significant disease? This is a fellow's course, so I should almost make everybody repeat after me the phrase, the cath lab does not equal a stent. I should really make you do it. You want to do it? Do it. The cath lab does not equal a stent. That's really important because everybody feels that interventional cardiology is just about doing PCI. And the reality is what we're trying to do for our patients is we're trying to diagnose what they have first and then determine what the best way is to treat them for what they have. And that's based upon their presentation, that's based upon the non-invasive testing, and that's based upon not only what we see in the cath lab, but also the other adjunctive tests we do in the cath lab. And so there's a dissociation here that we need to hardwire into our brains as interventionalists. We're trying to figure out what the patient has and then trying to figure out how to treat them best. And remember, in the cath lab, we not only do coronary angiography, we do hemodynamics, we do left ventriculography, which is important in selected cases, even aortography can be useful. So this is really critical. Back, I'd say about 20 years ago or so, if there was a sick patient in the ER, who did you call to make the diagnosis? You didn't call the echo attending to put an echo probe on. You called the interventionalist because we would figure out what was going on. And we've lost some of that. And echo is obviously very important. All the other adjunctive testing is important. But we can, I think, in many ways, integrate all those things together and then figure out how to treat the patient most effectively. Now, specifically, angiography itself is not just a straightforward thing where you take some pictures. It can be an art form. And the reason is you're projecting a three-dimensional structure in 2 dimensions. And that's an inherent limitation of the technique. It also means we have to be really assiduous in terms of how we take the pictures so as to get the best information to answer the diagnostic question that is plaguing the individual patient. So basic essentials, you have to engage the catheter selectively. The catheter can't shoot out as you're taking a picture because it won't opacify the vessels. You have to take appropriate views. You have to fully opacify the vessels without streaming to be able to make the determination of what's going on in the lumen. You need to make sure that you're minimizing radiation for yourself and the patient, but you're using enough to actually be able to see what's going on. And then you have to stay on long enough because you don't want the image to cut off before you can visualize a collateral, anomalous vessel, or some other issue like slow flow. One thing to remember, and this is basic stuff, but it's always worth going through it, is that the coronary arteries are complementary. So if you have a huge PDA coming off the right, you're going to have a smaller LAD and it's not going to wrap around the apex. If you have a huge circumflex that supplies the posterolateral wall, then you don't need large right coronary to supply the posterolateral wall as well. And so by thinking about this, and this becomes relevant in graft cases too, if you see a territory that's not being supplied by something, you need to think, am I missing a vessel? Am I missing a graft? Is there something that explains this? Because really at the end of the day, you should be able to piece together the whole coronary tree. So here's your sort of standard view from RAO. What you're looking at is down the AV groove. So coming towards you is the RCA, coming away from you is the circumflex, and then everything to the right of the screen is going to be the LAD. And so you need to make sure you can account for all these distributions across the 3 arteries. So it's not just looking at one picture and what the tight lesion is. It's looking at all the pictures together, integrating them to determine, can you explain what's going on with the coronary tree? And similarly, if you're 60 LAO, you're looking right down the barrel of the left ventricle, and in this view, you're going to see the right coronary coming off this way and the circumflex coming off this way. So remember, this is what the anatomy is, and you have to recreate that. This is kind of a historical picture on coronary angiography and how it was done originally with what cranial and caudal is. And I'm just going to refer you, this is from Boehm and Grossman. But remember, when you take angles, it's important to understand what you're seeing in each angle. So nowadays, we don't go back and read some of these original textbooks as much as we used to, but it is worthwhile reading and trying to understand which views opacify and show you which vessels. So this is an example of a case. Poor injection. Why do I say it's poor injection? Because the catheter comes out after the dye is injected. This is a vein graft. There's enough dye to fill the vein graft going up this way, but basically you're not seeing a lot because the dye is refluxing out. Let me just see if I can get this thing to play better. Hold on. So here, you wouldn't call anything going on in this territory, but it turns out when you look in a different view, you see how tight the ostium of the circumflex is. So you should know that in that original view, the LAD, the circumflex is going to be foreshortened, you're not going to see it, and you really need to do a good spider injection to be able to see that. Same sort of thing, here's a picture, the LAD looks great, everybody thinks the patient's fine. You're looking further, you can't really see this as much, and the same thing, you go LAO-caudal, and now you can see there's a lesion at the ostium of the circumflex here. This is an inherent limitation of angiography. This is why CT may be better in certain aspects for looking at this, but the way we overcome this limitation is we take better pictures and we take more comprehensive pictures. The other aspect of this is eccentricity. Not all lesions are concentric. They may only be on one side of the wall, and so if you're looking at it this way, you're going to see a lesion. On the other hand, if you look at it this way, from an orthogonal view, you don't see anything. The only thing you see is what's called some haziness because there's less visualization of this area than perhaps other areas of the artery because there's less contrast in the lumen at that point. This fundamental principle of eccentricity is why you generally need multiple views in order to truly call a lesion severe or not. And that's kind of illustrated by this. This is the X-ray source, here's the artery, and here's the screen. And basically, as the artery turns in this plane, you don't see any difference on the screen. On the other hand, as you change your view and you turn this way, now you see the difference. So the bottom line is if you're looking at only one view, it's going to be hard to sort out what's going on. Beyond just looking at what the lesion's severity is, you're also trying to characterize the lesion. Do you see it at a bifurcation? How tortuous this is? Where is it ostial? Is it in a vein graft? Is it diffuse? And is there thrombus, like a filling defect seen in an otherwise normal vessel? Beyond the lesions themselves, you also are looking, many interventional fellows fixate on this. They're going to see this. But are you actually looking at the film to look what the flow looks like in the vessel as well? It's not just the stenosis, it's also the flow. So here's an example of a patient, and patient comes to the cath lab, they have typical chest pain, interventionalist fellow takes this picture, and heart sinks. Nothing to treat. And first of all, we shouldn't obviously think that way, so I'm making a little bit of fun of that way of thinking. But the reality is if you look at the flow, there's profound slow flow in this vessel. And if you're only fixated on the lesion, you're not going to see the flow being slow. And so in this case, after giving nitroprusside, which is it's just downstream, obviously, than nitroglycerin in terms of the pathway, you see the flow normalizes. So what have you done in this patient? You've diagnosed microvascular dysfunction. You can reassure the patient, but you can treat them effectively. So your heart shouldn't sink. You should actually feel better because you have an answer as to why the patient came to the cath lab, and you can treat it successfully. This is another case that was actually referred to me as a second opinion. This is a young patient had chest pain with ST elevations on injection, and the interventionalist saw this flow abnormality down here and thought that this was thrombus. The patient actually was given 2B3A inhibitors and ultimately had a GI bleed from the 2B3A inhibitors, had a huge, ridiculous hospital course, and then came to see me. And in reality, this is not thrombus. What this is just not full opacification of the vessel because not a good enough injection was given. And so what you're seeing is mixture of blood with contrast, and there's no thrombus, there's no issue whatsoever with this vessel, and the patient was reassured. This is another patient, pre-op MVR. This is what the film looked like pre-op. Patient goes, has an MVR, gets sick as anything, and comes back to the cath lab, and this is post-op MVR. And I remember the first thing what the fellow said to me is, oh, the arteries look fine. They look the same. No, there's actually no circumflex because it was sewed off by the ring. So remember, you have to think about everything that's going on clinically and then use the test in the appropriate way to treat the patient as you go forward. There is a distinction between diameter stenosis and cross-sectional area stenosis. Basically, the diameter stenosis of 50% correlates to a cross-sectional area of 75%, assuming that the plaque is concentric. And 90% lesion correlates to a 99% stenosis in this way. This phenomenon generally doesn't come up that frequently, but this is generally why a cut point of 70% diameter is used to invoke a severe constriction of flow, or 90% by cross-sectional area. Notably, it did come up most recently with the publication of the Orbita trial, because in Orbita they report for some crazy reason percent area stenosis only. And percent area stenosis, what you may have heard, was 80% or greater, but it turns out it's actually percent diameter stenosis of 60%, which, by the way, is not a knock on the trial. It's just a way they would report it. In fact, in most DES trials, the percent diameter stenosis by QCA is around the same level, about 60% or so. But it's important to recognize there's a difference between diameter and area. The other thing is important is that things can be dynamic. So before nitroglycerin, this is a picture of what an LAD looks like. There may be an indeterminate lesion here. After nitroglycerin, you see the entire vessel dilates. And so this may have therapeutic implications for how you treat patients. This is another example of the same sort of phenomenon. This is before nitroglycerin. You see there's an area of 3.6. After nitroglycerin, the area goes up to 5.4. So these things are dynamic, and if there are questions, you can do pre and post nitro pictures in the lab, and certainly physiologic assessment's important too. Now, in terms of lesion length by angiogram, there's some pitfalls here, and the views are very important. The reason for that is that in this view, you can nicely measure the length of the mid-RCA. But if you try to measure the length of the PDA here, you can't, because the PDA is coming towards you. And the same thing is true on the left side. So this comes up with the concept of what foreshortening is. So what foreshortening is if you take your hand and you look at it straight and you look at the length of your pinky, you know how long your pinky is, and it looks long. But if you turn your hand towards you and you measure from this joint here to the tip of your pinky and you look at that length, it's going to be very, very short. That is what foreshortening is. So if you're looking at the artery in a non-orthogonal view, you're going to misestimate the actual length that the vessel is, and that's important when you turn in terms of things like stent sizing or otherwise. Here's just an example of that. This is the LAD in a spider view. This is the LAD in a cranial view. Look at the wire down here. This wire length is 30 millimeters. If you have a wire down here, that doesn't look like 30 millimeters, and that's because it's going away. So that's exactly what foreshortening is. Other things when you're in the cath lab, basic fundamentals, you don't want to inject with a damped pressure. We talked a little bit about this last night. If this is your baseline pressure, this is your pressure in your coronary artery. If you don't look at the pressure and you just inject, because that's how you always do it, well, you train to always do it wrong. You always need to look at the pressure first before you inject. And by doing so, you'll prevent this from happening. And this is a linear dissection down the whole length of the left main into the LAD. And this is an aortic cusp dissection from doing the same thing in the right coronary artery. So fundamental 101, and it's amazing how even through training, you sort of get old habits become lazy, and you get lazy with old habits. You can't do that. This is a habit that every single time, you look at the screen, look at the pressure before you inject. A few other things. So cath is the gold standard. Remember, patients in prior clinical trials, I mentioned the trials before, have been triaged on the basis of visually estimated angiography. The real question is, can we do better than that? I've mentioned issues with views. I've mentioned issues with eccentricity. There are a variety of things that can go on. And visual estimation it's important that things can be not exactly as they seem. In this view, in this picture, things look curved, but it turns out that all these lines are actually straight. They're influenced by these dots that make them look curved. And while in the cath lab, we're trying to do what we're doing based upon the pretest probability of the patient, that can also objectively change how we even call lesions. So if I take a patient and they have a classic story for angina, they have a positive nuclear stress test, and I show you a 60% stenosis, most interventionalists are more apt to call that 70 or 80% than if I take a patient with GERD resolved by Maalox, a negative stress test, and the exact same angiogram, in which case they may call it a 50. That's just a fact. That actually happens. So we have to be better than that, and how can we be better? Well, it turns out people tried to look at quantitative coronary angiography first as a way of doing this. That's sort of estimating the exact diameter of stenosis. It is more reproducible and there's less variation, but it's still limited by views, and it is still a pain to do a little bit. So there may be other ways to do it. And those other ways typically can involve either physiologic testing or imaging. In general, when you want to look at lesion severity, physiology is the way to do it. You do not image and come up with some cross-sectional area, and that's your determination of whether to treat or not to treat. The only exception to that is the left main, and Nick will talk a little bit about that tomorrow. In the left main, generally speaking, you can use a cut point of around 6 or 6.5. But outside the left main, imaging is out the window. You do not use it to determine whether to treat or not to treat a lesion. And this is just an example. Many people say, oh yeah, use FFR if you don't want to treat the lesion. Not true. This is a case of an LAD that most people would never call anything more than a 50% stenosis, FFR 0.71. Why? Because there's diffuse disease through this LAD itself. This is another case of a patient who has a calcified RCA and basically had this lesion. I actually called for the rotablator, and then I realized, I've remembered before obviously treating the patient, that this was my patient who was here in the cath lab because he had a positive CTA but a totally normal nuclear stress test, and we were doing a diagnostic to figure out what to do. I actually FFR'd this, and the FFR was 0.87. Truth, I left this alone. The patient's doing great. He actually, a week later, had a retinal bleed and needed surgery, and the ophthalmologist called me and said, is he on aspirin and Plavix? We need to stop this for his surgery. So I actually did leave this alone, and 3 years later, he's doing fine. And the reason I left it alone was because of the clinical scenario. So people always ask, well, do I need to FFR every lesion? Or do I need to do IFR in every lesion? Or when do I need to do it? Well, the reason, and to think about it, is in the cath lab, there's 3 inputs. There's the clinical scenario, and this is generally going to be a stable patient, not ACS. You're going to have non-invasive testing, or you may not, but that's the second input. And the third input is the coronary angiogram. And all these 3 things relate to each other. And the time to do physiology is not when you have a patient with classic symptoms, a severe lesion on the angiogram, and then you see this lesion. Because if you do FFR in that situation, like any test, if it's falsely negative, then you're in a weird situation. So what you want to do is when any of this is missing or equivocal, or discordant, that's when you can do physiology to figure it out. So people get in this whole system where exactly the scenario I mentioned, and I get called about this even from our own lab. You know, I have a patient with symptoms and they had a 90% lesion, but I did FFR and the FFR is 0.81. What do I do? Well, in that situation, the guy has symptoms, he has a positive stress test, treat the lesion, and this is not a dichotomous cut point, you know, red light, green light situation. And so this is kind of the construct that I use for physiology. When not to do physiologic assessment. This is a case that was presented at one of our fellows courses. CABG patient, non-STEMI. This is the lesion in the vein graft. There's antegrade filling of the vein graft, and because there was some collateral filling from the LAD, the operator opted to put a wire across this and do FFR of the vein graft to determine whether there was good collateral flow from the other side. This vein graft is about to go down. You don't want to do physiology in this situation. Treat the patient, not the number. Remember, coronary angiography also can be limited, and this is one of the other reasons. There's sometimes open vessels that may not actually be open. This is an example of imaging of this plaque. It looks open, but it's a little hazy because there's this ruptured plaque in this area as well. That's one of the reasons why people sort of feel that in ACS culprits, you tend not to do physiology because it may be a very dynamic process, and just because the physiology is okay now, it might not have been 2 minutes ago when the patient was actively having chest pain. Other scenarios, just briefly to talk about, left main, Nick will speak more about this, notoriously difficult to assess angiographically. We have a very low threshold in higher risk patients to do imaging or physiology in the left main. And there are other situations where this patient was referred for CABG. Turns out they had spasm. When we actually IVUSed it and did physiology, everything was fine and it was spasm. Some few pitfalls to think about: fewer inadequate projections, inadequate opacification, and I'm going to share these slides. I just want to go to the very last slide so you just remember one other thing not to do. We do see a lot of ventriculography that's done. If you're going to do ventriculography, you need to do it with a pigtail catheter. Please don't ever do this. And this is injection with this catheter actually has side holes, but it's not a pigtail type of catheter. If you're going to do ventriculography, you got to do it with a pigtail type catheter. Do not do it with an end hole catheter, even if it has a side hole, or a single JR4 or something like that with an automated injector. So just to sort of summarize, what was a clinical question and did you answer it safely? That's the reason to do an angiogram. You have to identify all the important information: what's the circulation, lesion severity, findings, and you have to try to do it safely and minimize contrast and radiation. The final slide I'll leave you by, this is something that Sunil Rao taught me, words to live by, and that is if you take somebody to the cath lab and do a non-diagnostic procedure, you really ought to think about that as a cath complication, because you did an invasive procedure on a patient and yet you didn't get the answer you needed to get. There are certain times when you'll try and then the risk-benefit ratio runs its course and you don't want to give too much contrast, but then always go back and think, what could I have done differently so as to be able to answer the question safely and effectively? So with that, I'll conclude, maybe have a couple comments for questions or comments, and then we'll go on to the next topic.